Um,
All right, hi everyone. Today we're going to be talking about esophageal cancer and pembrolizumab. So for our basic cancer research, it's going to be mainly talking about gastroesophageal cancers. So what is that? It occurs in the meeting point between the stomach and the esophagus, which is also known as the esophagogastric function, shortened to EGJ. We have a solid tumor type, which is categorized by location and relation to our EGJ. Our first type is going to be 1 to 5 centimeters above the EGJ. Type 2 is between 1 centimeter above and 2 centimeters below the EGJ. And then type 3 will be 2 to 5 centimeters below the EGJ. For our tumor suppressor gene, a major one to take notice of is the common mutation of the P53. So in one study, we found that 42% of people with EGJ tumors have shown mutations in that TP53. TP53 is the tumor suppressor gene that is responsible for producing the protein P53. And we can think of P53 as more of a police force for the genome. It provides cellular and genetic stability. So it does a lot of variety of functions, which includes arresting the cell cycle, signaling DNA repair, like double and single strand breaks and mismatches, directing cells into apoptosis when they are no longer functional, leading the cell into senescence or G0 phase when they do not need to be reproducing. So without this important regulator, DNA damage can quickly add up and the cell would continue to divide, creating more cells with the damage. So oncogene activations and hallmarks. Retinoblastoma oncogene normally arrests the cell cycle. So through hyperphosphorylation of this gene, it inactivates that. And P53 also becomes inactivated, while the PDL1 gene becomes overactive. And that PDL1 gene will stimulate tumor growth. The hallmarks for esophageal cancer, we have sustained proliferation of signaling, and that's just the constant signaling of cells to grow even without growth factors. Evading growth suppression, so that's avoiding tumor suppressant gene signaling and also deactivating them. We have resisting cell death. So since P53 does signal apoptosis, a mutation in this gene would cause them not to die when they were dysfunctional. Replicative immortality. So activating P53 extends the cell lifespan to about another 30 doublings. This opens up opportunity of loss for genetic material and chromosomes. Inducing angiogenesis. So one subtype of this does amplify our VEGF. That is a vascular growth factor. So that does recruit blood vessel growth. And then also invasion and metastasis, which is common in all types of cancer. Our subtypes will be squamous cell carcinoma that originates in cells in the epithelial lining, our top circle in the picture, usually in the upper or middle portion. And that's where TP63 is amplified, which is a transcription factor. We have adenocarcinoma, and that originates in cells that produce and release mucus in the esophagus. That's in the lower portion of the esophagus where it meets the stomach in our second circle there. With adenocarcinoma, VEGF is amplified, and there are some similar genetic abnormalities between esophageal cancer and stomach cancer just because of their close relation to each other. All right, on to epidemiology.
all right, so epidemiology is the disease in describing in person, place, and time. So our public health problem was esophageal cancer. So our risk factors that we found were smoking, drinking, obesity, HPV, race, age, and gender. When we were looking at the incidence rate analysis, we saw that 1.1% of all new cancer cases were esophageal cancer, and that made it a rare outcome. The rate of new cases of esophageal cancer was 4.2 per 100,000 men and women per year. However, the men were 3 to 4 times more likely than women to get esophageal cancer. Now, when we looked at the mortality rate, the death rate was 3.8 per 100,000 men and women per year. When we looked at place, The incidence and mortality showed that Eastern Asia dominated incidence rates and mortality rates. However, but when we looked at time, incidence mortality due to time in 1990 and 2020, global age standardized mortality decreased by 27.5%, but the incidence rate increased to 74.8%, which was about 311,289 cases to 544,076 cases. This trend could also show that the physicians were actively looking for the incidence cases, as well as implementing new treatment protocols due to mortality decreasing. Now, when we studied our risk factors, we wanted to do a case control study, studying the association of alcohol consumption and esophageal cancer. They were grouped by outcome, either having esophageal cancer or not having esophageal cancer. And they were interviewed on exposure/risk factor, like what type of alcohol that you were consuming, wine or heavy liquor, and then how much and how long. The study was adjusted for confounders that may influence the outcome, such as sex, age, educational levels, smoking, etc. And if you would see here in our highlighted area, we do have significant results showing that alcohol consumption does increase the odds of drinkers, odds of esophageal cancer in drinkers rather than never drinking. And that was over a twofold increase, with the highest being of hard liquor over 75 grams per day, showing that the odds ratio was over tenfold. Therefore, this association of this risk is very strong, and by reducing this exposure, it should decrease the incidence rate some. However, there was a two-part study to this, and it showed that smoking was such a strong influence that you might have to cut out both. Now, when we were looking at our intervention study of Pembrolizumab, we saw the Keynote 590 study. It was a double-blind phase 3 randomized placebo-controlled study, and it showed that the overall survival in the Pembro plus chemo was 12 months compared to just chemo of being 9 months. The hazard ratio was 27% reduction. And then when we look at the progression-free survival, the Pembro plus chemo was 6 months progression-free, whereas the chemo was 5 months. And this again showed a statistically significant result with 36% reduction. However, when we were looking at the cost-benefit analysis, we saw that it cost over $5,000 to make only 4 milliliters of the drug, and at least $100,000 per year to the patient. Now, this might not be cost efficient for the patient, and other avenues of first-line treatment may have to be explored. We also saw a risk-benefit analysis that showed that there were more adverse events related to Pembrolizumab, and even though it did provide a reduction in a better result for progression-free survival in patients with esophageal squamous cell carcinoma, 72% also experienced the common and manageable symptoms, whereas most of, like the rest of them, had adverse effects. So the clinical research.
Prognosis for esophageal cancer is usually really poor, just because most patients are not diagnosed until their cancer is in a later advanced stage. And this is because symptoms don't typically arise for patients until they're in a later stage. And these later stages experience distant organ metastases, so they have limited treatment options available. And then additionally, the cancer does cause tumor-related dysphagia, which is actually when they have difficulty swallowing, and this includes liquids and food. So their inability to intake nutrients does impact every organ in the body, which leaves them severely emaciated, reducing their prognosis and impacting their quality of life. And an average of 20% of patients diagnosed are alive after a 5-year following the diagnosis, and this is just because the diagnosis does rapidly progress. The staging system, which is shown in the picture on the right using the TNM system, is based on 3 things, which is going to be the extent of the tumor, which is how far it's grown into the wall of the esophagus, and whether or not it's reached nearby structures or organs. And then also the spread to nearby lymph nodes, which is going to be the middle column. And third is going to be the spread to distant sites, which is the far right. And this is like whether or not it's spread to distant lymph nodes or distant organs, such as the liver or lungs. And tumors involving the submucosa tend to disseminate and are mostly present in late stages of the cancer, leaving the overall cure rate low. And once a patient has positive lymph nodes, their survival rate is also decreased, because even if it's local, it is a risk factor for distant lymph node metastases. And the stages go through 0 to 4, and they change based on where it's spreading to and what the cells look like, which is called the grade. For treatment protocol, most are going to present with the progressive solid food dysphagia, and this goes for both subtypes. And then this can also indicate advanced cancer, and patients are often debilitated at the time of diagnosis. Once symptoms do develop, the cancer progresses rapidly, with metastases occurring, and a median survival rate after distant metastasis is only 5 months. And these are the 7 types of standard treatment. These are all going to differ on what is applicable to each stage of the cancer, especially when you get into later stages, since metastasis is occurring and the body is weaker and surgery often isn't available anymore. So pembrolizumab is an immune checkpoint inhibitor. And so this is going to bind to the PD-1 on T cells, as shown on the right, to prevent the PD-L1 on tumor cells from binding and forming the PD-1, PD-L1 pathway, which is upregulated in the tumor environment. And so when these are upregulated, the tumor cells are allowed to escape the immune system and continue growing. And it does so whenever it prevents binding, it enhances T cell anti-tumor activity, increasing immune control, killing tumor cells, and increasing the proliferation of tumor antigen-specific T cells in the secretion of cytokines. And this also triggers apoptosis of immune-mediated tumor cells. So this drug was designed to be taken in combination with chemotherapy and platinum. And this is so that way we can produce further effects such as decreasing PD-L1 expression and forming an adaptive immune response. And it does have a narrow therapeutic index just for safety and efficacy. So some common side effects are nausea and vomiting, fatigue, rash, diarrhea. But a negative impact to the patient's quality of life throughout the treatment is the development of tracheobronchial fistulas, which is a cause of the cancer. It's a late complication, but since it does negatively impact the patient's quality of life, it does fall under patient experience, and it's caused by direct invasion of the cancer through the esophageal wall and into the main stem bronchus. And additionally, patient life expectancy is only 4 weeks once this develops. For adverse effects, for infectious complications, these will consist of things like immune-associated pneumonia and acute respiratory distress syndrome, and decreased number of white blood cells in neutrophils, which is actually going to be a effect that would prevent a patient from continuing. The off-target effects that are expected from the drug as listed are all due to anti-PD-1, PD-L1 drugs, such as our drug, making T cells hyperactive, leading to anti-tumor activity in tumor tissues. This does also create side effects in normal cells because CD8 cytotoxic T cells, T lymphocyte-mediated cell lysis, releases tumor antigens from normal tissues, making them a target to the immune system. And this is actually called epitope spreading, which results in reduced immune tolerance. And this can also prompt the patient in developing an autoimmune disease. For treatment effectiveness, this is when each subgroup is going to vary in how they benefit from the drug. So squamous cell carcinoma is actually going to have a higher overall survival rate, while adenocarcinoma doesn't really display any difference. However, the drug could be deemed ineffective if the cancer gained resistance to it, which this would be possible if tumor cells began to upregulate alternative immune checkpoints, which would make blocking the PD-1, PD-L1 pathway insufficient in inhibiting the cancer cells. And then additionally, oncogene mutations would create primary resistance. And these are our sources.